Hello, my dear friends. So let us begin with discussion of FMGE questions asked from pathology. So in this discussion, the questions which are being further discussed, the topics which I will discuss are not just based upon the recall questions in the previous exams, but also some extra questions which are based on the same pattern. So without wasting any more time of yours, let us begin. So look at this first question here. Identify this cell with owl eye appearance seen in urine examination of renal transplant recipient. And this is the image which had been provided to you in the exam. And let us identify the key words in this question. So first is the cell has owl eye appearance, as you can see here. Within the nucleus of the cell, there is some intensely purple staining inclusion. I don't know if I can say till this stage. Could be a nucleolus, could be an inclusion. Then it is identified in the urine examination of renal transplant recipient. So why is this part of the history provided? Urine examination of renal transplant. So this is probably suggesting some underlying immunosuppression. So the patient could be probably on some immunosuppressant drugs and is now presenting with these kind of cells in urine cytology, all right. And the options provided to you are the CMV infection, EBV, Epstein-Barr virus, Hodgkin's lymphoma, and non-Hodgkin's lymphoma. So if you go back to where have you heard this term owl eye, right? You would have heard this term in Reed-Sternberg cells. Reed-Sternberg cells which are identified in Hodgkin's lymphoma. But this is a trick question. This is actually not the Reed-Sternberg cell, but is the cytomegalovirus inclusion which is seen and is identified in urine cytology. Now you must be thinking, why is it not a Reed-Sternberg cell and why is it a CMV infection? So let us move to another question which was asked in the next FMGE exam. So two similar questions, because you know what about these exams, you don't get a repeat question in the sense that you'll get the same language or the same image. You get questions asked on the same topics. So that is the fundamental principle of getting repeat questions and focusing on the repeat topics, right? So if you look at this cell is also showing owl eye appearance, and it is strikingly having two identical nuclei which I can say are mirror images of each other and are showing these prominent eosinophilic nucleolus, right? Prominent eosinophilic nucleolus, and these nucleoli are giving that eye kind of an appearance to these cells, right? This image is so beautiful, it almost looks like, you know, some person is staring at you from the microscope, owl eye appearance. And in this question, they have asked that what is the cell of origin? So, and the options provided to you are the macrophage, the B cell, CD4 T cell or the CD8 T cell. So if you know the answer that this is the classical or the diagnostic Reed-Sternberg cell, you would know what is the cell of origin. So the cell of origin of a Reed-Sternberg cell is actually the B cell. So this is the answer to this question. So there were two questions which I just showed to you. This also showed owl eye appearance and this cell also showed owl eye appearance, but yet the answers were different. So let us see what do we mean by owl eye appearance first and what conditions can this be seen. So this owl eye appearance, so this is the picture of an eye of an owl for you to understand it better. And if you see these two images, in the first image, this is the image of the Reed-Sternberg cell. So this is the Reed-Sternberg cell, and I can also call it as the classical or the diagnostic Reed-Sternberg cell. Why the diagnostic Reed-Sternberg cell? Because there are certain other variants of Reed-Sternberg cell as well, which we will subsequently discuss. Whereas in this picture, this beautiful photomytograph, this is also showing owli appearance, right? So there are two nuclei with very dense basophilic inclusions seen here. And not just the nuclear inclusions, you also see, if I zoom into this picture, that within the cytoplasm are certain pink, bluish pink speckles, basophilic speckles. So not just the nuclear inclusions, but you also see the cytoplasmic inclusions. You have the nuclear inclusions and the cytoplasmic inclusions. And this cell is the CMV infected cell. So not just the Reed-Sternberg cell, but also the CMV infected cell shows the owli appearance. But what is the difference? If you look at the RS cell, what is the color of the nucleus? The color of the nucleolus is eosinophilic. It is pink, bright. Sometimes it is seen very brightly eosinophilic, even more than this. So it has Reed-Sternberg cells are large cells with a typical size description of 15 to 45 micrometers, which is quite a lot. If you look at the sizes of RBCs, you know that they are 7 to 8 micrometers. And if you look at this cells, this is so huge that the nucleolus itself is the size of a small lymphocyte, right? So these are large cells, and the cytoplasm is amphophilic to eosinophilic. You would have heard of the term eosinophilic. You know what is basophilic. What is amphophilic? Amphophilic is in between. So it has some bluish tinge to pink cytoplasm. And these are large cells, and they are present in Hodgkin's lymphoma. And the different subtypes of Hodgkin's lymphoma have different variants of Reed-Sternberg cell, which I will explain to you. Then besides, there's no cytoplasmic changes, are they? No. The cytoplasm is looking normal. It's just amphophilic. No cytoplasmic changes as such. And surrounding these nucleolus within the nucleus is this clearing. So this is giving the owl eye appearance to the cell. Now, in contrast, if you look at the second image, so here you not just have the nuclear inclusions, but you also have the cytoplasmic inclusions. So when both of these inclusions are present, the cells are easier to distinguish from the RS cell, though there obviously cases also in which cytoplasmic inclusions are not that well made out. Then it becomes tricky, and the diagnosis is ultimately based upon the entire clinical presentation, the scenario, and which organ system are you seeing these cells in exactly. And CMV infected individuals are, CMV is just an opportunistic infection, right? So it would be seen in a setting of immunosuppression, etc. It would make your diagnosis easier. Then again, these CMV infected individuals do not just have nucleomegaly. So the nucleus is sometimes so large that it is occupying more than 50% of the cytoplasm, but also increase in the cell size. So it is not just the nucleomegaly and the prominent nuclear inclusion, it also has nucleomegaly and increase in the cell size. So these two are the typical examples of owl eye appearance, and this has been now been repeated so much in the last few exams. It's a very important topic, right? But these were the questions which have been asked up till now. What about the rest? So now that we know that the owl eye appearance is seen in the RS cells, the Reed-Sternberg cells, then also in the CMV infected cells, but also two more conditions which could be your future questions. And this is a bonus question, right? What have I shown here? These are cardiac muscle fibers. So it's a hint to you. Can you think of owl eye appearance in some kind of cells you would have read in some cardiac disease? If I tell you, you would have read this in rheumatic fever, rheumatic heart disease. Now many of you can think of the answer, I'm sure. So you see these cells, right? If you see these cells, Now, this is a longitudinal section of a cell and this is a cross section. Now, these cells, before I give up the answer, these cells, another hint, show caterpillar appearance of the nuclear chromatin. Caterpillar appearance in longitudinal section. Whereas in the transverse section or the cross section, they are showing this owl eye appearance. So, do you know the answer to this now? The answer to this is the Anishkow. The Anishkow cells which are seen in rheumatic heart disease. So, these Anishkow cells, they show caterpillar appearance of the nuclear chromatin in the longitudinal section and owl eye appearance in the cross section. Now, when we are discussing about the Anishkow cells, also remember that there are certain giant cells. There are certain giant cells which are seen in the same condition, that is the RHD. What is the name of those giant cells? So, those giant cells are known as Aschoff giant cells. So, these giant cells are seen in rheumatic heart disease and known as Aschoff giant cells. So, this is also a question for you. Then, let us look at that where else is this owl eye appearance seen. And this picture is again so beautiful. If I give you a hint that this organism is known as the old man of intestine. Because this looks so live, it just looks like two eyes are staring at you from this picture, right? And this looks like a mustache and hair. So these are actually the flagella of this organism, and this is a parasite. So what is the name of this parasite? The name of this parasite is Giardia lambia. So even in giardiasis, this owl eye appearance can be seen. So this is the take-home message for you in this question, that owl eye appearance is not just confined to the Reed-Sternberg cells. It can be seen in the CMV infected cells. It can be seen within the Anishkow cells of the RHD and also in Giardia lambia. Then, now that we are discussing the topic of owl eye appearance as well as the Reed-Sternberg cells, just a quick revision of the type of Reed-Sternberg cells you encounter. So, the classical Reed-Sternberg cells are the ones which I described to you. The classical Reed-Sternberg cells. Yeah, I think I'll write it here for better visibility. Classical Reed-Sternberg cells, right, which are binucleate. Two nuclei are mirror images of each other, two eosinophilic prominent nucleoli. Then again, besides the binucleate form, there is also the mononuclear variant of the Reed-Sternberg cell. The mononuclear variant. So as the name is suggesting, it has a single nucleus. So even these can be encountered in Hodgkin's lymphoma. But then, like there are different histological types of Hodgkin's lymphoma, there is one variant of Reed-Sternberg cell which looks as if it is lying in some empty spaces. Now it is looking, it is not actually that these are lying in empty spaces, looking because in tissue processing, the paraffin embedded tissues, when they undergo the different processes, it is that their cytoplasmic content is lost. So it looks like as if the cells are lying in empty spaces or lacuna. Lacuna means hollow spaces. So these are known as the lacunar variant of Reed-Sternberg cells, the lacunar variant of Reed-Sternberg cells. And do you know which histological subtypes of Hodgkin's are there encountered in? They are seen in nodular sclerosis. The nodular sclerosis variant, the type of classical Hodgkin's lymphoma. Okay, now that we know there is mononuclear variant, there is a lacunar variant, there is another variant and it has some fun name as well. What is this fun name? You know, this name makes me hungry. Does it to you? It is popcorn cell. Popcorn cell. Why? Because the nucleus, it is so delicate. The nuclear membranes are folding on itself that it has a very cleaving and so many indentations that this nucleus has popcorn kind of appearance, right? If you look, there are many lobations and intranuclear cleaving of the nuclear membrane. So these popcorn cells, also known as the LNH variant of Hodgkin cells or the Reed-Sternberg cells. What variant histological type of Hodgkin's is it encountered in? This LNH variant of the Reed-Sternberg cell is seen in the nodular lymphocytic predominant Hodgkin's lymphoma, NLPHL. We abbreviate it and call it as NLPHL, which is the non-classical type of Hodgkin's lymphoma. So, looking at these morphological types, you must be wondering that, oh God, I have just forgotten the histological types of Hodgkin's lymphoma. Don't you worry, we'll just recap that too in this brief table. And this table has been taken from the beautiful book that is Robbins. And you should know that there are two major types of Hodgkin's lymphoma. So the first one is the classical Hodgkin's lymphoma. And if there is classical, that means there would be a non-classical Hodgkin's lymphoma. So this non-classical Hodgkin's lymphoma has just one variant, right? And that variant is the one which has these LH cells, the popcorn cells. So it is easier to remember that the non-classical Hodgkin's lymphoma equals to NLPHL. And it is called as non-classical because it is different from rest of the Hodgkin's lymphoma, which are grouped together because of similar immunophenotypic features. Whereas the NLPHL, it is different from the rest because of the different morphology and immunophenotypic features. Within the classical Hodgkin's lymphoma are four variants. So the first one is nodular sclerosis. Then also you have the mixed cellularity, lymphocyte rich and lymphocyte depleted. Nodular sclerosis is actually the most common type of Hodgkin's lymphoma worldwide. But if the question is which is the most common Hodgkin's lymphoma variant in India it is mixed cellularity, right? Then there are two names which are similar and you can remember, lymphocyte rich and lymphocyte depleted. This is different from, however, the lymphocytic predominant, which is the non-classical, right? So lymphocyte rich and depleted in the classical, whereas predominant in the NLPHL, the non-classical. Now, one classical feature you remember is that the Reed-Sternberg cells, they are CD15 and CD30 positive. And these Reed-Sternberg cells are actually nothing but they are, if the germinal center B cells, they undergo crippling mutations in its immunoglobulin heavy chains and other Ig subfamily. So these crippled B cells, if they are not effectively removed from the body, that results in Hodgkin's lymphoma. So these Reed-Sternberg cells are the ones which are actually the tumor cells, the ones which have undergone these mutations in their genes. And these Reed-Sternberg cells, by means of crosstalk with the rest of the surrounding lymphocytes, plasma cells, eosinophils, the surrounding area, they bring them together, and that is why you see the classical reactive background in these lymphomas. So the Reed-Sternberg cells are CD15, CD30 positive in all of these variants, except for, like I told you, the non-classical is a different immunophenotype. So that one is actually CD15 and 30 positive. CD15 and 30 negative, but it is CD20 positive. CD20 is actually the B cell marker. So just remember, this has been asked in occasional previous exams, that is AIIMS, and it was asked in 2016 AIIMS that NLPHL is positive for CD20 but it is negative for 15 and 30. Then the next point that you should remember is that Hodgkin's lymphoma is also associated with an oncogenic virus. And which virus it is? It is Epstein-Barr virus. But not all Hodgkin's lymphoma have very high EBV association. So the two terms with nodular in them, right? The nodular sclerosis and nodular lymphocyte predominant. So these two are actually EBV negative, but the rest have good EBV association. Percentages, it is okay if you can't remember, right? But these three have EBV positivity. So that completes this part of the table, this difficult and dreaded table, right? Then again, when we look at the typical clinical features or looking at the prognosis and the age group of presentation, so the nodular sclerosis, which is the most common Hodgkin's lymphoma, I told you, remember, is seen mostly in young adults, right? And it is generally these patients, they present in stage 1 and 2 disease, and so they have a good prognosis. Then mixed cellularity, which is seen most commonly in India, it is greater in males, and then it is not just confined to the young adults. So even again in individuals older than 55 can show this type of Hodgkin's lymphoma. The rest three variants are actually relatively uncommon, and you should just know that lymphocyte rich and lymphocyte depleted both are seen in older individuals, right? So the lymphocyte, whether if you are old, it doesn't really matter if you are rich or if you are depleted of the resources because you can't enjoy. So older individuals. And HIV association. HIV association is seen more commonly with the lymphocyte, lymphocyte depleted variants. So if you remember this much, you can solve all the MCQs on Hodgkin's lymphoma. And so let us, okay, I will also tell you that now that you have finished, we have discussed the Reed-Sternberg cells, and we have discussed the different variants, and we have quickly revised the Hodgkin's lymphoma as well. When we discuss these CMV infections, I want you to remember certain other kind of nuclear inclusions as well. One is the cytopathic effects the viruses have. I want you to know that. And also, let us just briefly recap the different oncogenic viruses and which tumors they cause. So, okay. Let us first now see that CMV. CMV we just discussed has intranuclear as well as intracytoplasmic inclusions. And you know what are these type of nuclear inclusions which are seen in CMV? They are known as Cowdery type A inclusions. Now, if they are Cowdery type A inclusions, they must also be Cowdery type B. So, Cowdery type A, like seen in CMV, are accompanied by these large intranuclear inclusions within the nucleus. Whereas Cowdery type B means that there is some smudging, right? There is some smudging of the nuclear chromatin. So that kind of cytopathic effect is known as Cowdery type B, and it is specially seen in HSV. So then what happens in HSV is also you should know. HSV is typically associated with 3 M's. What is HSV associated with? 3 M's. And what are those 3 M's? I'll show this diagram to you to make it easier to understand. One is there is multinucleation. One is there is multinucleation. Then the neighboring cell borders are closely opposed to each other, almost changing the shape. Changing the shape is known as molding. Right, this is known as molding, and you know, because they are so closely packed together, multinucleated in a single cell cytoplasm, this is sometimes also known as eggs in a basket appearance. So all pathologists are foodie, and if you look at the different similes we have, we tend to compare almost everything with food, right? So eggs in a basket appearance. Then multinucleation, molding, and margination. What margination of what? Margination of the nuclear chromatin. So the nuclear chromatin at the periphery is, say for example, darker in appearance, whereas in the center it has a paler appearance, so margination. So these three terms you should know. And where is this HSV, the cytopathic changes seen? These cytopathic changes in HSV are actually seen, where have you heard of this herpes simplex virus infection? You have heard it as a genital infection or an STD, right? So the squamous cells, sometimes even the glandular cells, that is the epithelial cells of cervix, especially example in the pap stained cervical smears, you tend to encounter these HSV changes. Even on H&E you can find them. So it is seen in the epithelial cells. Now the viruses can be, to remember these inclusions, sometimes it becomes a trickier subject. These viruses can be the DNA viruses or the RNA viruses. It is mostly the DNA viruses which are associated with intranuclear inclusions and the cytopathic effects. Intranuclear inclusions are seen in DNA viruses. RNA viruses, on the other hand, they don't form these kind of inclusions, except for another question which is asked just so many times. It has been repeated twice in the previous two NEET exams, which is measles. And now you would remember that measles, a certain kind of giant cells are seen which are Warthin-Finkeldy kind of giant cells. And these Warthin-Finkeldy giant cells, they are giant cells with multinucleation, and these nuclei, they show inclusions. These nuclei show small inclusions, right? And they are seen in lungs. The lungs, that kind of pneumonia which is seen due to the measles infection, even this has been asked in the previous exam, it is the hex pneumonia. Sorry, it is actually the hex pneumonia. I think this is the spelling. Check it please, I'm not too sure. So hex pneumonia. So hex pneumonia is seen due to measles infection, and the kind of giant cells you encounter are the Warthin-Finkeldy giant cells. Then also the RSV virus is another exception to this. RSV, respiratory syncytial virus. So though it is not forming any intranuclear inclusion. So RNA viruses, they don't form intranuclear inclusions except for measles. But RSV virus, on the other hand, do show certain cytoplasmic changes. And those cytoplasmic changes are the appearance of pink speckles. So like the CMV was showing purple speckles in the cytoplasm, RSV shows pink speckles in the cytoplasm. This is one thing. Then even rabies is an RNA virus. So these three examples, if you remember, for RNA viruses, everything else comes under the DNA viruses, the nuclear inclusion. So the rabies show certain bodies in the cytoplasm of the nerve cells they infect. What are those bodies known as? They are known as Negri bodies. Alright. So coming back to the intranuclear inclusion seen in the DNA viruses, we have read about CMV, we have read about HSV. Then what about HPV, human papilloma virus, associated with cervical carcinoma. And it is herpes, this HPV virus, human papilloma virus, it actually also is not showing any intranuclear inclusions, but it shows very characteristic cytopathic effects. And these again you should be knowing, because these cytopathic effects, if you see in a cervical smear, that is almost diagnostic of the lower, the L cells, right? So low-grade squamous intraepithelial lesion, that is. So cytopathic effects of HPV is very classical, in which what do you see? You see a cell with its nuclear membrane showing wrinkling, sometimes giving it a racinoid appearance, and within the cell around this nucleus there is a perinuclear halo. perinuclear halo. So a cell with wrinkling of its nucleus surrounded by a clear halo due to margination of the cell's cytoplasm. That is the characteristic cytopathic effect of HPV infection. So if you know these intranuclear inclusions, that is good enough. So you may encounter an entire list in your books, but those are seldomly asked. So let us move on to another important topic which is pertaining to these two questions, and that is the oncogenic viruses. And to discuss the oncogenic viruses, let us move on to the next question. So this question was again asked in FMGE exam, that nasopharyngeal carcinoma is associated with which virus? And some of you might be knowing this answer, some of you would be scratching your brains that which virus, was it the CMV, was it the HSV, the HPV? The answer to this question is Epstein-Barr virus. The answer to this question is Epstein-Barr virus, and this Epstein-Barr virus is, mind you, not just associated with nasopharyngeal carcinoma, my friends, it is associated with plethora of different neoplasms, certain non-neoplastic conditions in pathology, which you ought to know. And well, to remember that, let us move to something fun kind of a mnemonic I have made for you, and a break to your scratching the brains. Okay, this question, image-based, very important question, that who is this person? Who is this person? The answer is given here. So this person is Mark Ronson. And with Bruno Mars, he has made this very popular song, at least I love this song, which is Uptown Funk. And if you go to the weird lyrics which are to this song has very catchy music, but it certainly has certain debatable kind of lyrics, doesn't it? So with the help of those lyrics, I'll help you remember the neoplasms which are associated with EBV. I hope Mark Ronson doesn't sue me for this. Okay, so this is this person, the great Mark Ronson, and he will help us remember the EBV associated lesions. So EBV, first of all, you should be knowing EBV is actually HHV. Which? HHV1, is it 2, 3, 4, 5, 6, 7, 8? It is actually 4. Epstein-Barr virus, Barr has 4 letters, so you can remember 1, 2, 3, 4. It is HHV4, one thing. Then, okay, so in this song, what are the lyrics to this song? Okay, so just let us erase this, okay, for some time. And the lyrics to this song are, I am hot, he keeps on saying, I'm just too hot, hot damn, something like that, right? Let me figure out. Okay, this is, so this person, he keeps on saying, I am hot. So with help of this, you can remember I, infectious, mononucleosis, IM. So infectious mononucleosis is caused by which virus, my friends? The answer is Epstein-Barr virus. Then he says, I'm too hot, right? Hot, you can remember Hodgkin's lymphoma. Hodgkin's lymphoma. So you read that Hodgkin's lymphoma just 3 minutes ago, you read, right? Hodgkin's lymphoma has a very high association with the Epstein-Barr virus, except for the nodular sclerosing and the nodular lymphocytic predominant Hodgkin's, that is NLPHL. Rest of the 3 subtypes are associated with Epstein-Barr virus. Then it is associated with another lymphoma. And which lymphoma is that? To remember this, just have a look at his goggles, right? His goggles are shaped like B. Can you think it is shaped like B if you have imagination like me? So from B comes Burkitt lymphoma. Now, especially the endemic Burkitt's lymphoma, which are commonly seen in the African subcontinent, wherein a young child, he presents with massive jaw swelling, massive lymphadenopathy. So that is associated with Epstein-Barr virus, Burkitt's lymphoma. Then again, just have a look at his hat. And why is he wearing this hat, with this pink flower? So this pink flower is actually probably not present in his actual hat, but just this is my fun touch to it. So he's wearing this hat to hide his hair. Actually, this Mark Ronson is going bald, and he's going bald because he doesn't have hair. So you can remember hairy leukoplakia of the oral cavity. So hairy leukoplakia was asked in one of the previous exams, is also associated with Epstein-Barr virus. So this much you have remembered. Now look at his nose. So from this you can also remember that it is associated with nasopharyngeal carcinoma. It is associated with nasopharyngeal carcinoma, which was the question. Then not just the nasopharyngeal carcinoma, it is also associated with nasal type of NK T-cell lymphoma. So this is a sort of a newer entity, hematological malignancies, and this nasal NK T-cell lymphoma. You can also remember because it is associated with nasal masses, etc. It is also called as lethal midline granuloma. So that's a different topic. Nasal NK T-cell lymphoma. Then again, if you look at his feet, he's wearing these kind of boots. And these boots, if you can maybe try to resemble them to letters L and G. So it is also associated with lymphomatoid. Granulomatosis. So this is also a condition. I won't go into detail, but remember, lymphomatoid granulomatosis is also associated with EBV. Then there are certain other, these are actually bonus questions. So if you remember, just the hairy leukoplakia, Burkitt's, Hodgkin's, and infectious mononucleosis nasopharyngeal, you are good to go. But then these are certain bonus questions. So people who are hungry for more information should also remember that lymphomatoid granulomatosis, and besides this, plasmablastic lymphoma, which is generally actually encountered in HIV infected individuals, plasmablastic lymphoma, primary effusion lymphomas, which are also associated with HHV8, and also post-transplant lymphoproliferative disorders. So these three are extra, and besides this, a variant of DLBCL, which is EBV positive. So if you remember these also, it's good enough. But with the help of mnemonic, I have covered the ones which are at least important at this undergraduate level. So once you know that EBV causes these many lesions, so let us also just quickly revise what are the other oncogenic viruses, right? So HPV, like I told you and you all remember, is associated with cervical carcinomas. And this HPV can be low risk and it can be high risk. So the low risk HPVs are 6 and 11, and the high risk HPVs are 16, 18, 31, 33. So these are associated with cervical carcinomas. This every one of you knows already, I'm 100% sure. But the examiners have also become smarter now. So they may not ask you that HPV associated with, and they may ask you that HPV is associated with, and either you won't get the cervical carcinoma in options, or you might get these kind of questions in multiple type of in kind of questions in which you have to answer multiple options, right? So it is also associated with anogenital lesions. Then also it is associated with warts and it is associated with laryngeal papillomatosis. And also, much research has now concluded that even oral squamous cell carcinomas, they relate with HPV infections, right? So these all you should know. Then HHV8. HHV8 is associated with Kaposi sarcoma and even primary effusion lymphomas. But Kaposi sarcomas, Kaposi sarcoma, which is actually the malignant lesion of the blood vessels. Kaposi sarcoma is associated with HHV8 and also HIV infection. Then HTLV, human T-cell leukemia virus, is associated with adult T-cell leukemia lymphoma. So if you are able to remember these many oncogenic viruses, you are good to go. Okay, so let us move to another topic and another question, that is a 65-year-old man. The 65-year-old man is suffering from chronic renal failure, and because of which he is on hemodialysis, right? So this history has been provided to us. Then he developed carpal tunnel syndrome. Which of the following is associated? And in these, which of the following you have been provided with different amyloid subtypes? So, the thing about many students, they say that with the different patterns of the exams, the questions are so lengthy. First of all, each question has 6 or 7 lines that, I find it very difficult to answer. On the contrary, my friends, I would like to say to you, it is a very good thing that, first the questions have become clinically integrated. Then again, because there are 7 sentences, in each sentence there is a hint to the answer. So in factual one-liner kind of questions, there is no other option, right? If you know, you know. If you don't know, you don't know. But in these questions, you have so many hints कि तुम्हें याद आ ही जाएगा. You will be able to remember what you are trying to. So first hint which has been provided to you is that the patient has had hemodialysis and is now presenting as carpal tunnel syndrome. So the answer to this question is beta-2 microglobulin. Though this is actually a factual question. So to answer this, let us revise this table from Robbins. And if you see, amyloidosis could be systemic, it could be localized, and this systemic can be due to different like the primary, secondary amyloidosis due to different conditions, or it could be even hereditary. So when we look at the generalized kind of amyloidosis, remember that primary amyloidosis is associated with multiple myeloma. The kind of amyloid is AL. L for light chains. So multiple myeloma. Secondary amyloid is AA, and it is seen in chronic inflammatory conditions. For example, in rheumatoid arthritis also it is seen. And the third is beta-2 microglobulin. It is hemodialysis associated amyloidosis seen in chronic renal failure. So this question has been asked, and this table is actually very, very important from Robbins. Then if we look at the hereditary kind of amyloidosis, so these might be a bit tricky to remember, but there is no other way out, my friends. So familial Mediterranean fever. Familial Mediterranean fever is associated with AA, like it was seen in secondary amyloidosis. So fever, maybe you can remember that fever is an inflammatory condition, right? And inflammation is associated with secondary amyloidosis. So maybe this way you can remember. Then there are 2. One is familial amyloidotic neuropathies, right? And then there is a systemic senile amyloidosis. So both are associated with transthyretin deposition, amyloid which is derived from transthyretin, so called as ATTR. But then there is a difference in the kind of transthyretin which is deposited here, and this can be a future question, and that is that the systemic senile amyloidosis is associated with mutant. This is associated with the wild type. the senile amyloidosis is associated with the wild type of transthyretin, whereas the FAN is associated with mutant transthyretin. Maybe you can remember in old age, people may tend to go senile and wild, so wild type associated with systemic senile amyloidosis. Maybe this is a way you can remember. But anyhow, transthyretin is the amyloid that is deposited. Second is localized amyloidosis, and A beta protein deposition in Alzheimer's, everybody is aware of, derived from amyloid precursor protein in Alzheimer's. Then if there is type 2 diabetes, it is associated with endocrine kind of amyloidosis, and the islet amyloid peptide. The islet amyloid peptide is the one which is associated with the islets of Langerhans, and medullary carcinoma of thyroid, because it releases calcitonin, is associated with this amyloid. Also easy to remember. Then there is another isolated atrial natriuretic factor. These you can very well remember. The most important being A beta. Then these are important because these are fancy names, and these you already know. So that was the thing about amyloidosis. And a very sad question, that is Congo red staining is diagnostic, which shows apple green birefringence. So it's a easy question, and sometimes easy questions, most of the questions are easy, so get easy questions also in the exams. Then I have made this picture for you, that where else have you heard of this term beta 2 microglobulin. So this beta 2 microglobulin is part of this structure which is known as the MHC 1 molecule, which is present on all the nucleated cell. And not only is it associated with hemodialysis associated amyloidosis, but this beta 2 microglobulin is associated with different, is used to prognosticate multiple myeloma. You must have heard in the staging, if beta 2 microglobulin is raised in multiple myeloma, it is associated with poorer prognosis, and even in other certain kinds of lymphomas. So you have heard this term here, and also in the MHC1 molecule, right? So let us begin to the next question. Let us go to the next question, which is a post-mortem examination of heart in a 78-year-old man, an elderly man that is, and who died due to pneumonia. Some extra bit of information which has been given. Maybe they are suggesting that the heart disease was not the cause of death. Heart disease, the kind of finding you are seeing here, is an incidental finding. So they show that there is perinuclear deposition of some yellow-brown pigment. And what is this pigment? So pigment deposition also you should know, and especially in an aging individual with perinuclear deposition, which is this pigment. This pigment is it hemosiderin? Is it lipofuscin? Is it pneumoconiosis? Or is it hemozoin? So the answer is simple, and it is lipofuscin. And this lipofuscin pigment is also known as wear and tear pigment because it is associated with aging, mostly an incidental finding, and it is associated with aging and with free radical damage. So it is also known as telltale sign of free radical injury. So this is also a question, which is telltale sign of free radical injury? Answer is lipofuscin. So this lipofuscin is an endogenous pigment, and it is yellow brown in color, and it tends to deposit around the nucleus. It is perinuclear in location, and it's a physiological pigment. And it is very commonly seen in males, especially in the aging ejaculatory ducts and the seminal vesicles. In aging heart, a question can be asked. There is a gross appearance due to deposition of this brown colored pigment, and that gross appearance is known as brown atrophy of heart. When this pigment it deposits in eyes, it can lead to macular degeneration as well. And certain even neurodegenerative disorders are associated with lipofuscin. We won't go into that detail. Then special stain for lipofuscin, because this lipofuscin is actually a combination of protein as well as phospholipids. Stains like Sudan black, which is actually a typical lipid stain, can identify lipofuscin as well. Though identifying lipofuscin is not of much importance, I would say, but differentiating it from another golden brown pigment, which is hemosiderin, is important. And hemosiderin, like you know, is the iron containing pigment, and which is the special stain which is used to identify hemosiderin. The special stain used to identify is pearl stain. Pearl stain. This pearl doesn't have an A. PERLS, which gives a Prussian blue reaction or Prussian blue staining to the iron pigment. Then besides hemosiderin, even malarial pigment is black in color and can be confused sometimes, and even melanin. What is the stain used to identify the melanin? It is Mason Fontana. So these all are just the questions, potential more questions which can be related to this brief and easy question. So let us discuss another question. So okay, now we have a hematology question and a long question. So like I was telling you, long questions are not just too bad, right? So have some patience, read that question carefully and keep on highlighting or underlining the key points. So a 30-year-old man is presenting to the emergency room, alright, with a history of fatigue, fever and bleeding comes for the past 3 days. His physical examination is revealing notable ecchymosis and gingival bleeding. So more emphasis to this gingival bleeding is given. Then patient's WBC count is 18,000. Alright, so there is leukocytosis, which is the normal range. It is generally 4 to 11,000 per microliter. So there is leukocytosis. Hemoglobin is 9.4. So he certainly has anemia. And platelet count is just 22,000. So it has to be more than 1.5 lakh or more than 1 lakh. Then the WBC differential notes, the differential, that is the DLC, the differential leukocyte count is showing some lymphocytes, monocytes, eosinophils and 60% others. So there are some other kind of cells, right? Some atypical cells which they are calling as others. So by this history itself, we know that there is a person whose TLC is increased, hemoglobin is decreased, platelets are decreased, and there are certain other cells. Then the patient has symptoms of these low platelets, that is gingival bleeding, could be a coagulopathy, right? So the peripheral smear shows characteristic population. I don't even need to go to the picture. I'm just, through the history, I'm able to make out that there are certain dark published cytoplasmic granules within these cell populations. Some have even dumbbell-shaped nuclei. The patient has been admitted for initiation of treatment. Then fish analysis documents a translocation 1517. So now this itself is more than enough hints have been provided. Translocation 1517 is associated with a kind of acute myeloid leukemia. And which is that leukemia? That leukemia is there in one of these options for you. ALL, is it acute lymphoblastic leukemia? Is it Burkitt's lymphoma? Is it AML-M6 or is it APML? APML is acute promyelocytic leukemia. So the answer is APML. So, okay, let us also look at the images, because sometimes just the images can be provided to you, not with this lengthy explanation. So there is this, probably the bone marrow, and it is showing, or the peripheral smear. So they have told that this is a peripheral smear and it is showing these large cells. So lymphocyte is there in the background for comparison, and there are these other cells These other cells besides the nucleus are showing these intracytoplasmic bodies. What are these? These are OR rods. And where are OR rods seen? They are seen in myeloblastic leukemias, acute myeloid leukemias. So we know that this is AML. What kind of AML? In AML with these large cells, abnormal promyelocytes, which when stained with the cytochemistry, which is MPO stain, show very dense and diffuse cytoplasmic positivity. The cytoplasmic positivity is shown by this black colored appearance. Blue, it's actually dark blue to black. So this is classical case of APML. And this APML, acute promyelocytic leukemia, they generally present with coagulopathy. Acute promyelocytic leukemias, they present with coagulopathy, DIC, or due with excessive fibrinolysis. Because there is excessive fibrinolysis, a hint may be provided to you that the blood shows increased D dimer and increased FTP levels. So we have discussed this when we discussed DIC in theory lectures, right? So it is associated with these two findings. Then again, the cytochemistry shows this intense MPO positivity. That is one thing that you should know. And the typical translocations, which is the translocation 1517, also known as PML RARA, which is diagnostic of APML. Now, what if I tell you that suppose there is an individual who has suppose 5% these abnormal promyelocytes in the blood and still is showing translocation, this 1517, is it still a leukemia? The answer to this is actually yes. So there are certain exceptions. There are certain exceptions to the rule of periphery or the bone marrow showing more than 20% blasts, and that is 3 characteristic mutations, translocations. One is translocation 1517. Then if there is translocation 16 or inversion 16, that is also diagnostic of acute myeloid leukemia even with blasts less than 20% in the bone marrow. Then again translocation 821 is one such diagnostic translocation. Now this is not must know, but this is good to know. So if you can remember, that's great. Then a quick recap of how these myeloblasts are different from lymphoblasts. So recently a one-liner question also came in this INI-CT exam, that is the Indian PG exam, that myeloblasts, they are, which of the following blasts show OR rods? So OR rods are seen in myeloblasts, and it's a very stat question. So besides myeloblasts, there is also lymphoblast, which is seen in acute lymphoblastic leukemia, and this myeloblast excess more than 20% is seen in AML. Alright, so the lymphoblasts, as you can see, are smaller in size. They have a very, if you look at the nuclear chromatin, the nuclear chromatin is very relatively homogeneous, it is fine, and there is a thin rim of pale blue cytoplasm, agranular cytoplasm, right? These are the ones which are seen in lymphoblast. Myeloblasts, on the other hand, are much larger, and if you see, the chromatin is opened up with prominent nucleoli. And besides this, if an OR rod is present, that is a 100% sure shot sign that the cell belongs to an myeloid lineage. Though ore rods are not always seen in myeloblast, but if ore rod is seen, that is diagnostic of the cell being a myeloid origin cell. So that is one thing. Cytochemistry, I told you MPO is positive in AML, whereas PA's positivity, especially block-like positivity, is seen in lymphoblast. And what color does this PA's positivity give? That gives pink block positivity at the periphery. So these points are good to revise. Okay, let us go to the other question, and which is that a 9-year-old boy presents to the emergency with repeated episodes of breathlessness, wheezing and cough. His symptoms relieved on nebulizing him with bronchodilators. So what does it sound like to you? It sounds like asthma. So the child has wheezing, cough, and they have given bronchodilators and he has symptomatically relieved. The question is not what is the clinical diagnosis. The question is what type of hypersensitivity reaction would these symptoms indicate? Is it type 1, is it type 2, 3 or 4? So what does it indicate? Okay, so that indicates that this is a type 1 hypersensitivity reaction. Type 1 hypersensitivity reaction is not just asthma, all allergies. So if this clinical history is provided to you in the form of an allergy, suppose allergic rhinitis or allergy to cats or pollen grain, something like that, that is also type 1 hypersensitivity. So not just asthma, which is this question. Type 1 hypersensitivity examples are also anaphylactic reactions, anaphylaxis. Type 1 hypersensitivity is sometimes also known as atopy. You can remember this as allergies as well, right? So all allergies, asthma, anaphylaxis, they fall under type 1 hypersensitivity reactions. Type 2 hypersensitive reactions, on the other hand, also known as cytotoxic kind of hypersensitivity, is when antibody, it goes and binds to fixed antigen present on the cell membrane. So if it binds to the fixed antigen on the cell membrane, it will trigger downstream activation of different inflammatory cytokines, complement activation, which will lead to cell lysis. Type 2 hypersensitivity. Type, I'll write here antibody, and I will write here allergies. Then type 3 hypersensitivity ones are those in which there occurs immune complex deposition, right, at various places. And the fourth is the delayed type of hypersensitivity. Delayed hypersensitivity. Why am I writing here? Because there's also another simple way to remember this, which is A, B, C, D. A is 1, B is 2, C is 3 and D is 4. So type 1 hypersensitivity associated with allergies. Type 2 associated with antibody deposition. Type 3, which is C, associated with complex depositions, that is immune complex depositions. And 4 is D, that is delayed hypersensitivity reaction. Which brings us to another important table from Robbins, that is, I have put some tables from Robbins because these are the tables which you cannot just afford to forget before your exams. And if you have them placed in some particular notes or at one place before the exams, if you just brush up through them, most of the MCQs you'll be able to solve. Though these tables are a bit tricky to remember, but if you understand, you will never forget. So the type 1 hypersensitivity, which is the classical example shown here, is associated with production of IgE antibody. IgE antibody is the one which is responsible for allergies. And so what happens is, if there is an allergen exposure to an individual first time, so that results in sensitization of the individual to that particular allergen in the form of the mast cells expressing increased IgE antibodies on their surface. next time when there is a re-exposure to that allergen the individual is sensitized to, that results in cross-linking. So there is a cross-linking of the IgE which occurs on the surface of mast cells. Mast cells, you have read in inflammation, are the ones which release important cytokines and important mediators of inflammation. There are certain preformed mediators like histamine and serotonin, which result in all of these clinical symptoms like wheezing and cough, bronchoconstriction, etc. Then also there is activation of some newly synthesized mediators as well, like interleukin 4 and 5, which recruit eosinophils. And when eosinophils also come into play, that is the reason why in blood of asthma, in allergic individuals, you tend to see eosinophilia. So try to correlate like that. And this is the example which we have already discussed. It is also good to know that type 2 hypersensitivity is the classical example given are the hemolytic anemias, when these antibodies, they go and bind to the RBC antigens and lyse them. Goodpasture syndrome, when they go and bind to the antigens on the kidney as well as the lung. Then immune complex mediated type 3 hypersensitivity, when there is immune complex deposition. It is seen in SLE and certain other forms of glomerulonephritis, serum sickness and Arthus reaction. Type 4 hypersensitivity, delayed, remember, granuloma. Granuloma formation is a type of type 4 hypersensitivity reaction seen in tuberculosis, and also contact dermatitis and multiple sclerosis, if you can remember. Alright, so shall we proceed to the next question? Okay. So the next question is, which of the following diseases show a deposition of tau protein? A one-liner question, but the answer to this question, if you look at the options, rabies, Creutzfeldt-Jakob disease, Parkinson's and Alzheimer's. If it is a kind of question which is asking only for one option, the answer is Alzheimer's, right? Because this is a classical reason why the neurofibrillary tangles are formed in Alzheimer's disease, because of abnormal tau protein which gets deposited. But you know what? This tau protein is not just seen in Alzheimer's, it is also seen in Parkinson's and some other neurodegenerative disorder. If the question was which of the following diseases show a deposition of alpha-synuclein, then the answer would be Parkinsonism. So though Parkinson's is classically associated with alpha-synuclein deposition, it also has tau protein deposition. And Alzheimer's is associated with A beta protein deposition, which is amyloid, and besides that there is tau protein deposition. So this A beta, that is amyloid, is the one which gives rise to the pathological finding, which is the plaques, as the tau protein give rise to the finding which are the neurofibrillary tangles. So do you remember what are these tangles and what are these plaques? So if we look at a typical brain biopsy from an individual with Alzheimer's disease, so Alzheimer's disease presents with dementia. It is actually the commonest cause of dementia in older individuals. And if you look at the brain section, you know, it's very interesting. If we look at the brain section, there are two classical findings. So one is plaque deposition and the other is tangles. So what are plaques? Plaques are nothing but entangled A beta proteins. And how are these A beta fragments formed? So the cytosol of these nerve cells on their surface. So on their surface, they have these amyloid precursor protein expressed on them. So there is recruitment of certain enzymes like the alpha and the gamma alpha and gamma secretase in normal individuals, whereas beta and gamma secretase in these Alzheimer's disease. So what does this beta secretase enzyme in place of alpha do? That they cleave this APP at such site that this A beta, which is this amyloid protein, that is produced instead of the normal monomers. And this A beta protein fragment which is produced, it is very sticky. And because it is sticky, so it is not lysed. It tends to form oligomers, and these oligomers, they combine with other oligomers and they form larger fragments which are not soluble. So these larger fragments, they go and they deposit extracellularly. So if suppose these are the neurons and they're intercommunicating, there are a lot of intercommunicating intercommunications which are taking place. So these abnormal A beta proteins, they go and they get deposited extracellularly, right? So these extracellular depositions of these A beta proteins are known as plaques, and they hamper the neurotransmission. And because they hamper the neurotransmission, depending upon which area of the brain these plaques are being deposited in, different kinds of impairment in memory and cognition and reasoning, judgment, etc. is clinically manifested. So that is one thing, plaques. Then what are tangles? Tangles are actually seen intracytoplasmically, intracellularly. So suppose this is a neuron, right? It has a cell body and then it has dendrites. Now within the axons are microtubules. These microtubules, they provide not only a structural framework to these axons, but they also act like railroads. They also act like railroads to the transmission of different chemical mediators and nutrients from the cell body to the dendrites. They take part in communication. So these microtubules, they are like railroads, and these railroads are actually supported by tau proteins, right, in normal healthy individuals. What happens in Alzheimer's? That these tau proteins are not being produced normally, and because they are produced such, they tend to accumulate. So instead of helping the microtubules in neurotransmission and playing a role in providing the framework to the cells, these tau proteins are non-functional, because of which there is loss of integrity of the microtubules. And not only are these tau proteins not providing the required framework, they are also getting accumulated, right? So these tau proteins, they tend to get accumulated within the cell. And when they do, when these tau proteins, which are actually fibrils, when they get deposited, they are known as neurofibrillary tangles. Neuro because they deposited in the brain tissue, fibrillary because they have a fibrillary fibers like appearance, and they are getting tangled together. So that is the pathophysiology behind neurofibrillary tangles. So remember, in Alzheimer's there are plaque deposition and there are also these tangles deposition, and they are seen in Alzheimer's disease. A beta protein deposition is the one which is responsible for plaque formation in the Alzheimer's disease. Then tau protein, this is again a Robbins table, is not just seen in the Alzheimer's disease. So if the option is to select one best option, answer would be Alzheimer's. But if there were more, it is also seen in Parkinson's disease and even progressive supranuclear palsy and whatnot. Then also within this table, it is important to remember that alpha-synuclein is the one which is seen in Parkinson's disease deposition. Alright, so can we move ahead? Okay, image-based questions from Robbins again. So if you look at these two pictures, these are nothing but what I had explained to you just now. So this is a section from the brain right? And that is the cerebrum. And if you look closely, there are certain pink blobs, some fuzzy wool-like deposits. These blobs are the ones which are the plaques. And these plaques, because these are composed of these A beta proteins, if I on an H&E, as you can see, they are very difficult to identify. I really have to strain to identify, okay, this is one, this is another one, this is another one, this is another one. They can be highlighted by silver stains, right? So silver based stains, and especially the one which is used in nervous tissue, it would be great if you can remember, that is Bilskowski stain, silver stain. So that will identify these plaque deposition very well, black color deposition. And even IHC is available now for A beta protein, which can identify these, right? So it can be identified by silver stains, which are not that specific though, and IHC for A beta protein. Then there are also tangles, and these tangles can also be detected using tau protein immunohistochemistry as well, right? So tangle deposition can also be seen in Alzheimer's. If this is asked as an image-based question, would be a difficult question. But now that you have seen this image, you'll be able to answer. There's nothing much except for these blob deposition which you have to find out. Okay, so let us move to another question from hematology. So, in your typical exams, you don't get questions like 6 questions from anatomy, then I'll give 5 questions from physiology. No, the questions are mixed and they're randomly placed. Even in pathology, the questions will be around 30-35 in the 300 exams, 300 questions, but those questions would be isolated. Some would be such that you may think these are medicine questions, these are surgery questions, but if you know pathology, you'll be able to answer those questions as well. So the question here is a very sad and a simple question. We tend to like these kind of questions, right? Which of the hematology conditions is this peripheral smear finding seen? And which is this peripheral smear finding? So the examiners are so sweet, they have also provided us with arrows. So they are telling that, look, these are the normal red blood cells, these are the platelets. What are these cells? What is their shape like? They are teardrop cells. Teardrop cells. What is the other name of teardrop cells? Teardrop cells are also known as dacryocytes. Fancy term, huh? But teardrop cells are also known as dacryocytes. And if you know why they are seen in the peripheral smear, it would be very easy for you to identify the cause. So the answer to this question, if you look at these options, sickle cell anemia, beta thal trait, myeloproliferative neoplasms, or myelofibrosis, the answer is myelofibrosis. And myelo is what? Myelo is bone marrow, right? And if there is fibrosis in the bone marrow, what happens is this fibrosis would not let the RBCs which are being formed to come out of its fibrotic depositions. And while trying to go out from the bone marrow, while trying to go out through this resistance pathway, they tend to get deformed. And when there is so much of fibrosis, they look, while coming out, like teardrop cells. So just imagine the RBCs trying to squeeze out from the narrow spaces, and because of which it results in deformation of their shape. So myelofibrosis is the reason for teardrop cells. And actually, not just, are there teardrop cells here? Right. So not just myelofibrosis. If there is a condition which is known as myelophthisis or myelophthitic anemia, which is when the bone marrow is actually infiltrated, when it is infiltrated by, say for example, tumor cells, or the bone marrow is having some granulomatous inflammation occurring inside. So that also results in the bone marrow RBCs not being formed properly and being released as teardrop cells in the circulation. Then again, even severe iron deficiency anemia can form teardrop cells, and even in thalassemia major, not in trait. Trait would have almost like a normal appearance or mild microcytic hypochromic anemia without poikilocytosis. So these are the causes of teardrop cells. If you still find it difficult to remember, just visualize that the RBCs, they cry if they are pushed away from home. So RBCs, they are being pushed away from their home, which is the bone marrow, either because of myelophthisis or because of myelofibrosis, and because of being thrown away from their home, they cry and look like teardrop cells. That is one thing. Quick recap of the different shapes and sizes of the RBCs. Shapes, that is sizes, microcytic, macrocytic, all of you know. Normal cell is the typical RBC is biconcave and it has central 1/3 of pallor. However, if there is a loss of this pallor because of increased concentration of hemoglobin into RBC, because of decreased surface to volume ratio, decreased surface to volume ratio because of loss of its cell membrane due to genetic conditions like hereditary spherocytosis, the results in microspherocytes, right? Also, certain conditions like burns and certain infections like Clostridium infection, they also show spherocytes. Even in autoimmune hemolytic anemia, there is loss of the membrane of the RBCs, and the microangiopathic hemolytic anemias. Though there is a predominance of fragmentation which occurs in MAHA, spherocytes can also be seen. But these causes are good enough, you can remember. Microspherocytes especially are seen in hereditary spherocytosis, whereas burns, infections, AIHA, they'll show spherocytes. Then sickle cells. What condition are sickle cells seen? They are seen in naturally sickle cell anemia. Sickle cell trait-minded, those individuals don't show sickle cells in the peripheral blood unless they are exposed to certain oxidant stress, like the metasulfite test, which is used as a screening test. They don't show the traits, they don't show peripheral smear sickle cells. In sickle cell anemia, not just the sickle cells, but even certain board-shaped cells can be seen. And if sickle cell is coexisting with HBC, certain deformed poikilocytes can be seen, which are known as SC poikilocytes. It's okay if you don't remember these, but it is important to remember, can be asked as image-based question. Then are elliptocytes. Elliptocytes are nothing but elongated cells, elliptical in shape, unlike the circular RBCs. They are seen in hereditary elliptocytosis. Like there is hereditary spherocytosis, there is also hereditary elliptocytosis as well. This hereditary elliptocytosis, though rare, but it is commonly seen in iron deficiency anemia as well. Then important question, target cells. Target cells are nothing but they look like a target because within the central pallor, there is a condensed hemoglobin as well. So giving this target-like appearance. Seen in severe iron deficiency anemia, seen in thalassemias, can be seen in sickle cell anemia, hemolytic anemias as well. So if I show you the picture of this teardrop cell, if I were to ask that which is this cell and which is this cell and which is this cell, so these are target cells. Right? Though it can be seen in many conditions, these are the important causes. Then we come to the fragmented cells and the ones which are seen in hemolytic anemias. So fragmented cell known as a cystocyte. So this fragmented cell is known as a cystocyte and it is seen in fragmentation syndromes like DIC, HUS, TTP, And even HOS and TTP are quite similar, but TTP also has neurological symptoms. Then also it is seen in individuals with prosthetic cardiac valves. So if this kind of suggestive history is given to you, even without looking at the picture, you can just answer that you will be having fragmented RBCs. Then also some other named RBCs, one being the echinocyte, which is somewhat like circular but has numerous projections on the surface which are almost equal in size, in contrast to acanthocytes, which are also known as spur cells, which has these long thorn-like projections. So this echinocyte is seen in chronic renal failure as well as in uremia. These acanthocytes, on the other hand, are seen in spur cell anemia and typically in alcoholic cirrhosis of liver, which also shows the macrocytic anemia, non-megaloblastic kinds, alcoholic cirrhosis. And because if there is suppose a deformed cell membrane which is formed because of abnormal lipids, A-beta lipoproteinemia, that also manifests as acanthocyte. There are certain neuroacanthocytes also which are seen in neurological conditions. Perhaps the only thing which, if you remember, the most important ones being these dicryocytes, spherocytes, target cells and cystocytes. Please don't forget at least these and their causes. Rest, it would be good if you can remember. So let us move to the next question, and that is again a long question and an image based question, right? So this question says that there is a 24-year-old male and he is actually old treated case of tuberculosis, okay, and he's presenting with cough and hemoptysis. So put that picture in your head. But then they're saying that CT chest at present shows a mass. CT chest is showing a mass within the cavity wall which is separated by an air space, air crescent sign. So have you heard of this term, air crescent sign? Okay, try to recollect. Meanwhile, another hint is provided to you, that is from that lesion they have done a fine needle aspirate cytology, FNAC has been done, smears have been made, stained, and this is the image which is shown to you. So what is the diagnosis? Is it carcinoma lung? So going by a mass, some may be thinking it's a carcinoma lung. So just don't go by one word. There are just so many other terms which have been provided. And what about this structure here? Is it carcinoma lung? No, it is not. Is it asbestosis? No, not at all. Is it reactivated tuberculosis? Is this history of TB being provided here? But what about the mass, the air crescent sign, and this thing which is seen here? It is also not tuberculosis. It is actually aspergillosis. So this is the aspergillus, the fungus, which is giving all of these signs. And which is this sign? This is the air crescent sign which has been given to you in this question. So either you may be provided next time by not this image but just this sign which is air crescent sign, or a radiological image may be provided to you in the absence of the cytological picture. So questions can come anyhow. So this is CT scan, and this view is showing this air crescent sign. What is this air crescent sign? Air crescent sign is actually, crescent is this, right? So actually there is this radiolucency, a thin rim of radiolucency which is being seen in a nodule of radio opacity or a nodular opacity, and this is characteristic sign of aspergillosis. So even if I didn't look at any of the hints that is provided in the question, if I knew this one radiological sign, I can answer this question, and that is aspergillosis. So what really this aspergillus organism do is that it tends to invade the pulmonary veins of the lungs, and by invading the pulmonary vasculature, it tends to cause infarct. And this infarct, though it is temporary, it tends to get resolved. So this infarct is visible as that radio opacity, and while the time it is taking to resolve, that area of the dissolution of this infarct would be visible as this air crescent sign. So just for your information, and this air crescent sign is obviously non-dependable because it is not because of the fungal ball per se, but because of the necrosis. Air crescent sign seen in aspergillosis. But what is the role of the pathologist here? So the pathologist would not just be able to diagnose this aspergillus, but also differentiate it from mucor, which is also a slightly more resembling fungus, but we can differentiate these two if we know the differentiating points. So the aspergillus infection, the aspergillus organism, these tend to form narrow and septate hyphae. So if you look, these are these narrow hyphae which have these septations, right? You can see these septations, right? And they have acute angled branching. If you look at some, is it showing some branching? Okay, so this Y-shaped branching which is being seen here. So acute angled branching. From A aspergillus, remember they are associated with acute angled branching. So if you go back to maths, acute is what? Less than 45, less than 90, less than 90 degree. But these mucor are associated with right angle branching, right? Right angle branching seen in mucor, and these are broad aseptate or pauciseptate ribbon-like hyphae. Remember, so aspergillus versus mucor, aspergillus acute angle branching with thin septate hyphae. Mucor on the other hand are broad ribbon-like aseptate hyphae. Confirmation can be done by culture, but the histological findings are enough to confirm whether asper or mucor. Then special stains of the fungus are two more potential questions with this topic. So what stain is shown here, which is highlighting the cell wall as pink in color? It's deep pink or magenta. So the stain used is PAS, which is the periodic acid shift reaction. Also remember, this PAS not only stains the fungal organism, it is used as a stain, special stain, which we'll discuss in the special stains lecture for a host of other things. Periodic acid shift reaction. Here in this lecture only I have told you one use, which is to differentiate lymphoblast from myeloblast. Lymphoblast, they show block-like positivity by PAS stain, right? Which is the same PAS which is used here. Then it may be, the fungal wall may be stained by certain silver-based stains like the silver-methamine. It can be Grocott silver-methamine, right? Or the GMS stain like that. So silver-methamine stains them black. Two special stains, two questions. All right. So let us move to the last question, and if you know the answer to this question, you are good to go. So a 10-year-old child presents with massive neck swelling due to lymphadenopathy, and the biopsy shows the following finding. What is the most likely diagnosis? So we have a clinical picture provided of a child. What looks like to be the ethnicity of this child, if I may ask? So this child could be of African descent, presenting with a massive jaw swelling, and the biopsy from his lymph node is showing this picture. And can you identify this is a low power view or if it is a high power view? So I can't tell at this power which cells are these, can I? But I can say that this low power view, or maybe the scanner view, this is actually a scanner view which is 4x, and it has been provided to you because this finding in itself is the one which will help you catch the diagnosis. And which is this finding? This finding is starry sky appearance. So do you know where starry sky appearance seen? It's seen in one lymphoma. Which lymphoma? Which is associated with EBV. And EBV, like I told you in this lecture, is associated with Burkitt's lymphoma. And this Burkitt's lymphoma is the one which shows starry sky appearance. And what kind of lymphoma is it? A B cell lymphoma? Is it a T cell lymphoma? It is actually a B cell lymphoma, a mature B cell neoplasm. And so the answer is this. And it is actually a B cell lymphoma with very high proliferative index, and because the cells are produced and they're lysed so much rapidly, it has very high Ki67 index, and also it is very commonly associated with tumor lysis syndrome. And you know what? Why this starry sky appearance is due to? Are these stars in the so-called sky the abnormal cells? No, these are actually the normal follicular dendritic cells which are going to try and eat up these necrotic debris. So these normal follicular dendritic cells are the ones the pale cells which are strikingly seen in the contrast of monomorphic population of the deep blue mature B cells. So this B cell lymphoma, it's a B cell lymphoma and it is derived from the germinal center. So it is BCL6 positive, CD10 positive, CD20 positive, which are the B cell markers. Then again, it is associated with c-MYC translocation. So if we go back, to that mnemonic I told you of the Epstein-Barr virus, the Bruno Mars and the Uptown Funk one, this one. So I forgot to tell you one thing. So if you look at this picture again, there is this mic, right? There is this mic. So maybe you can remember this way, that associated with c-MYC translocation, the Burkitt's lymphoma, that is. Okay. So Burkitt's lymphoma associated with c-MYC translocation, and the translocation which is seen is the 8-14-1. 8-14. It can also be associated with 2-8 and 8-22. So which is common amongst them? 8. And 8 is the one which chromosome 8 is the one which harbors this c-MYC gene. So these are the important questions when it comes to Burkitt lymphoma. Starry sky appearance, Burkitt lymphoma. But not just Burkitt lymphoma. It also, you have seen certain other conditions which I'll just tell you about. But one more point, what is this picture showing? This is Burkitt's leukemia. And when would we call this as leukemia? When these tumor cells, the B cells, these monoclonal B cells, if they are seen in the peripheral blood or if they are seen in the bone marrow. And these cells, they have these vacuolar deposition in the deep blue rim of cytoplasm. These vacuoles are actually lipids, and this kind of leukemia is actually acute lymphoblastic leukemia only. Why? Because these are the B cells, right? Acute lymphoblastic leukemia, which in the older FAB classification was actually ALL type 3, right? And because they are lipids, so not only are these cells showing lipid deposition, these tiny vacuoles would be positive for Sudan black. So that is another point you should remember. And this photo could have been given to you in this clinical scenario as well. So this starry sky appearance, like I was telling you, is not just confined to the lymph node in Burkitt's lymphoma. And you know what? This same Burkitt's lymphoma, if it is seen in the bone marrow defined biopsy, then it doesn't show this starry sky appearance. It's only in the lymph node wherein it tends to show this. You would have also heard of this in some immunofluorescence finding, and this immunofluorescence, if you can identify which tissue is it. This is kidney. Which condition? Lumpy bumpy deposits. I've given you a hint. Lumpy bumpy deposits of IgG in a condition which is post-streptococcal glomerulonephritis. So as you can see, like stars in a sky, black sky. So it is also seen in kidney and also in radiology. In radiology, this is a section of brain, and due to calcification of certain parasite, this sign is seen, starry sky sign. And what is it due to? It is due to neurocysticercosis. So now you know that this starry sky appearance, like the owl eye appearance, which is seen in so many conditions, can also be seen in kidney as well as in neurocysticercosis. Sometimes even the ultrasound findings in acute hepatitis are being given, the resemblance of starry sky appearance. But these 2 points you should know. So now that you know that the answer to this question is retinoblastoma, and this picture is showing flexner intestinal rosettes, you should know what are the types of rosettes. And rosettes are such a high yield topic that it can be asked in one way or the other and has been previously asked as well. So rosettes can be classified into 2 broad categories: pseudo-rosettes or the true rosettes. Now these true rosettes, depending upon whether in center they have the neuropil or whether in center they have lumen. So if in the center there is a blood vessel, so imagine the rosettes to be like a wheel in which the spoke surrounding the central hub, there are different spokes. These spokes of the wheels are formed by these nuclei of the cells, right? If a blood vessel is present in the center, that is certainly a pseudo-rosette. And the classical example of a pseudo-rosette or this pseudo-rosette is exemplified by ependymoma, in which around the central blood vessel, are these radiating cells. Though ependymoma not only shows pseudo-rosette, it also shows the true ependymal rosette. That's a different thing. But pseudo-rosette's example you should know is ependymoma. Even in central neurocytomas, pseudo-rosettes can be seen. But if in the center of this wheel, if the hub is formed by either the neuropil, which earlier was believed to be pseudo-rosette, but now if neuropil is present in the center, that too is a true rosette. So if in the center there is nothing, there is a lumen, or if in the center there is neuropil, that is true rosettes. And the classical example of true rosette with neuropil in the center are the Homerite rosettes. And these Homerite rosettes, neuropil, neuroblastic tumors. The host of the neuroblastic tumors show true rosettes, the Homerite rosettes. For example, the neuroblastomas, the medulloblastomas, all the primitive neuroendocrinal tumors, even pinealoblastoma. So when in doubt, if the differentiation is neuroblastic, think of true Homerite rosettes. Even retinoblastoma can show these Homerite type of rosettes, and the retinoblastoma can show flexner intestinal rosette as well. What are flexner intestinal rosettes? Flexner intestinal are the luminal rosettes, in which in the center there is a lumen and surrounding which are the tumor cells. So flexner intestinal seen in retinoblastoma, and these kind of rosettes can also be seen in carcinoids. Yeah. So these are the examples which you should know, and it will be very easy for you to remember if you remember these pictures in your brain. And that completes our discussion for the important questions, and I hope you found this as high yielding. And the topics which have been discussed in this video are very high yield topics, and if you go back and just revise them, you'll be able to solve so many more questions as well. Thank you.